features of coordination impairments as the cerebellum, basal ganglia, and dorsal column, medial limniscal pathway provide input to, and act together with, the cortex in the production of coordinated movement. Lesions in any of these areas affect higher-level processing and execution of coordinated motor responses. Although it is incorrect to assign all problems of incoordination to one of these sites, lesions in these areas are responsible for many characteristic motor deficits seen in adult populations. The following sections present an overview of common clinical features associated with lesions in each of these areas. Cerebellar pathology. A number of specific motor impairments that affect coordinated movement are associated with cerebellar pathology. Many of these impairments either directly or indirectly influence the patient's ability to execute accurate, smooth, controlled movements. The motor deficits identified emphasize the crucial influence of the cerebellum on equilibrium, posture, muscle tone, and initiation and force of movement. Ataxia is perhaps the most common term used to describe motor impairments of cerebellar origin. Cerebellar ataxia is a general, comprehensive term used to describe loss of muscle coordination as a result of cerebellar pathology. Ataxia may affect gait, posture, and patterns of movement and is linked to difficulty initiating movement, as well as errors in the rate, rhythm, and timing of responses. Perlman provides an adept summary of the motor impairments associated with each of the major anatomic regions of the cerebellum as follows. The cerebellum has three anatomic divisions that account for the three types of dysfunction commonly seen. 1. The midline, vermis, palliacerebellum, which underlies titubation, truncal ataxia, orthostatic tremor, and gait imbalance. 2. The hemispheres neocerebellum to the power of, right controlling the right side of the body and left controlling the left side, which contribute to limb ataxia, for example, dysdiadochokinesia, dysmetria, and kinetic tremor, dysarthria, and hypotonia. And 3. The posterior flocculonodular lobe, archocerebellum, which also influences posture and gait as well as causing eye movement disorders, for example, nystagmus, vestibulo-ocular reflex disruption. The following motor impairments are manifestations of cerebellar pathology. Asthenia is generalized muscle weakness associated with cerebellar lesions. Dysarthria is a disorder of the motor component of speech articulation. The characteristics of cerebellar dysarthria are referred to as scanning speech, often described as having a one-word-at-a-time quality, or words may be broken into separate syllables. The speech pattern is typically slow and may be slurred, hesitant, with prolonged syllables and inappropriate pauses. Word use, selection, and grammar remain intact, but the melodic quality of speech is altered. Dysdiadochokinesia is an impaired ability to perform rapid alternating movements. This deficit is observed in movements such as rapid alternation between pronation and supination of the forearm. Movements are irregular, with a rapid loss of range and rhythm, especially as speed is increased. Dysmetria is an inability to judge the distance or range of a movement. It may be manifested by an overestimation, hypermetria, or an underestimation, hypometria, of the required range needed to reach an object or goal. The synergia, movement decomposition, describes a movement performed in a sequence of component parts rather than as a single, smooth activity. For example, when asked to touch the index finger to the nose, the patient might first flex the elbow and then adjust the position of the wrist and fingers, further flex the elbow, and finally flex the shoulder. Asynergia is the loss of ability to associate muscles together for complex movements. Gait ataxia involves ambulatory patterns that typically demonstrate a broad base of support, BOS. Upright stance stability is often poor and the arms may be held away from the body to improve balance. High guard position. Stepping patterns are irregular in direction and distance. Initiation of forward progression of a limb may start slowly, and then the extremity may unexpectedly be flung rapidly and forcefully forward and audibly hit the floor. Gait patterns tend to be generally unsteady, postural instability, irregular, and staggering, with deviations from an intended forward line of progression, veering to one side, swaying or pitching in different directions. Hypotonia is a decrease in muscle tone. It is believed to be related to the disruption of afferent input from stretch receptors and or lack of the cerebellum's facilitatory efferent influence on the fusimeter system. A diminished resistance to passive movement will be noted, and muscles may feel abnormally soft and flaccid. Diminished deep tendon reflexes also may be noted. Note: after testing the patellar tendon jerk with a reflex hammer in a normal subject, the knee typically returns immediately to the resting state. With cerebellar pathology, the knee may oscillate 6 to 8 times before returning to rest. Nystagmus is a rhythmic, quick, oscillatory, back and forth movement of the eyes. It is typically apparent as the eyes move away from midline to fix on an object in either the medial or lateral field, that is, extremes of temporal or nasal vision. The patient has difficulty holding the gaze on the object in the peripheral field. An involuntary drift back to midline with immediate return to the object may be observed. Nystagmus causes difficulty with accurate fixation and vision and is believed linked to the cerebellum's influence on synergy and tone of the extraocular muscles. Rebound phenomenon, originally described by Holmes, is the loss of the check reflex, or check factor, which functions to halt forceful active movements when resistance is eliminated. Normally, when application of resistance to an isometric contraction is suddenly removed, the limb will remain in approximately the same position by action of the opposing muscles. For example, in applying resistance to an isometric contraction in the middle range of elbow flexion and then releasing it without warning, the intact subject will change to the power of or stop the motion quickly through activation of the opposing triceps, as well as feedback regarding joint position and force required to prevent further motion. With cerebellar involvement, the patient is unable to stop the motion, and the limb will move suddenly when resistance is released. The patient may strike himself or herself or other objects when the resistance is removed. Tremor is an involuntary oscillatory movement resulting from alternate contractions of opposing muscle groups. Different types of tremors are associated with cerebellar lesions. An intention tremor, or kinetic tremor, occurs during voluntary motion of a limb and tends to increase as the limb nears its intended goal or when speed is increased. Intention tremors are diminished or absent at rest. Postural, static tremor may be evident by back and forth oscillatory movements of the body while the patient maintains a standing posture. Postural tremors also may be observed as up and down oscillatory movements of a limb when it is held against gravity. Titubation typically refers to rhythmic oscillations of the head, side to side or forward and backward movements, or the movements may have a rotary component. However, the term is also less frequently used to refer to axial involvement of the trunk. In addition to these characteristic clinical features of cerebellar involvement, a greater length of time may also be required to initiate voluntary movements, delayed reaction time. Difficulty may also be observed in stopping or changing the force, speed, or direction of movement, prolonging movement time. Motor learning will also be affected. Recall that the cerebellum compares the intended movement, internal feedback, with the actual movement, external feedback. For subsequent movements, the cerebellum generates corrective signals to reduce the errors, feed forward control. Lack of this feed-forward control is responsible for deficits in motor learning and coordination. Basal ganglia pathology. Patients with lesions of the basal ganglia typically demonstrate several characteristic motor deficits. These include 1. Poverty and slowness of movement, 2. Involuntary, extraneous movement, and 3. Alterations in posture and muscle tone. Thus, patients with basal ganglia involvement present on a continuum of motor behavior from severely diminished as seen in advanced Parkinson's disease to excessive extraneous movements apparent with Huntington's disease. The following motor impairments are manifestations of basal ganglia pathology. Akinesia is an inability to initiate movement and is seen in the late stages of Parkinson's disease. This deficit is associated with assumption and maintenance of fixed postures, freezing episodes. A tremendous amount of mental concentration and effort is required to perform even the simplest motor activity. Athetosis is characterized by slow, involuntary, writhing, twisting, wormly to the power of movements. Frequently, greater involvement in the distal UEs is noted. This may include fluctuations between hyperextension of the wrist and fingers and a return to a flexed position, combined with rotary movements of the extremities. Many other areas of the body may be involved, including the neck, face, tongue, and trunk. The phenomena are also referred to as athetoid movements. Pure athetosis is relatively uncommon and most often presents in combination with spasticity, tonic spasms, or chorea. Athetosis can be a clinical feature of some forms of cerebral palsy. Bradykinesia is a decreased amplitude and velocity of voluntary movement. It may be demonstrated in a variety of ways, such as a decreased arm swing, slow, shuffling gait, difficulty initiating or changing direction of movement, lack of facial expression, or difficulty stopping a movement once begun. Bradykinesia is characteristic of Parkinson's disease. Chorea is characterized by involuntary, rapid, irregular, and jerky movements involving multiple joints. Choreiform movements demonstrate irregular timing, are most apparent in the UEs, and cannot be voluntarily inhibited. It is associated with Huntington's disease. Choreoathetosis is a term used to describe a movement disorder with features of both chorea and athetosis. Dystonia, dystonic movements, involves sustained involuntary contractions of agonist and antagonist muscles, causing abnormal posturing, dystonic posture, or twisting movements. Most common in trunk and extremity musculature, but also may affect the neck, face, and vocal cords. Torsion spasms also are considered a form of dystonia, with spasmodic torticollis being the most common. Hemiballismus involves large amplitude, sudden, violent, flailing motions of the arm and leg of one side of the body. Primary involvement is in the axial and proximal musculature of the limb. Hemiballismus results from a lesion of the contralateral subthalamic nucleus. Hyperkinesis is abnormally increased muscle activity or movement. Hypokinesis is a decreased motor response, especially to a specific stimulus. Rigidity is an increase in muscle tone causing greater resistance to passive movement. It tends to be more pronounced than the flexor muscles of the trunk and extremities, causing activity limitations in such areas as dressing, transfers, speech, eating, and postural control. Two types of rigidity may be seen: lead pipe and cogwheel. Lead pipe rigidity is a uniform, constant resistance felt by the examiner as the extremity is moved through a range of motion. Cogwheel rigidity is considered a combination of the lead pipe type with tremor. It is characterized by a series of brief relaxations or catches to the power of as the extremity is passively moved. Tremor is an involuntary, rhythmic, oscillatory movement observed at rest. Resting tremor. Resting tremors typically disappear or decrease with purposeful movement, but may increase with emotional stress. Tremors associated with basal ganglia lesions, for example, Parkinson's disease, are frequently noted in the distal UEs in the form of a pill rolling to the power of movement, where it looks as if a pill is being rolled between the first two fingers and the thumb. Motion of the wrist and pronation and supination of the forearm may be evident. Tremors also may be apparent at other body parts as well, such as the jaw. This is characteristic of Parkinson's disease. Table 6.1 provides a summary of common coordination impairments associated with the pathology of the cerebellum and basal ganglia.
So, that was the cerebellum and basal ganglia disorders readings from O'Sullivan. I have the 7th edition, so those page numbers are different on in my book. So I made a snip of the table and then I kind of blew it up, so the cerebellar pathology is on one slide and the basal ganglia pathology is on another slide. Okay, so upper motor neuron and lower motor neuron lesions. I got this out of my school notes. The upper motor neuron is going to be part of the central nervous system. It's comprised of neurons whose cell bodies are located in the brain and the spinal cord. The lower motor neuron is a part of the peripheral nervous system, and it's made up of motor and sensory neurons with cell bodies located outside of the brain and spinal cord. So, upper is in, the lower is out. So, upper's in, lower's out. The upper motor neuron lesion, it interrupts a neural pathway at a level above the anterior horn cell. Motor pathways in the cerebral cortex, internal capsule, cerebral peduncles, brainstem, and spinal cord. So it interrupts a neural pathway at the level above the anterior horn cell. The lower motor neurons interrupt a spinal reflex arc. All clinical features result from a lesion of spinal motor neurons, the motor root, or a peripheral nerve. So the lower motor neurons, they interrupt a spinal reflex arc, and the upper motor neurons interrupt a neural pathway at the level above an anterior horn cell. Signs of the upper motor neuron lesion: you're going to have weakness, and it's going to be present in all the muscle groups. Abnormal mediation of voluntary contraction of anti-gravity muscles. So the lower limb, you're going to have greater weakness of the flexor and abductor muscles. The upper limb, you're going to have greater weakness of the abductor and extensor muscles. So the lower limb is the flexors, like hip flexors, knee flexors, and the upper limb is going to be the extensors, triceps, shoulder extension, wrist extension. Okay. Very little muscle wasting because there's no loss of trophic factors normally released from the lower motor neurons. The signs of the lower motor neuron lesion, you're going to have weakness, but it may be more obvious distally than proximally. So more weakness in your hands versus your shoulders, your knees versus your hips. And equally involved, and your flexors and extensor muscles will be equally involved. And the wasting is a prominent feature. I cannot say those words. Fasciculations, maybe present. Okay. Upper motor neuron spasticity. You're going to have destruction in the cortico-reticulospinal tract. Cortico-reticulospinal tract spasticity, which results in a stretch reflex hyperactivity. Increased tone is present, may be clasp knife, often associated with clonus. So you're going to have a lot of spasticity. You're going to have spasticity develop with an upper motor neuron lesion, spastic upper. Those upper people can get very spastic. You know what I'm saying? Those uppity people get very spastic. The lower people are usually chilled, chilled out. They're just kind of loosey-goosey, hanging out. We're kind of like down here on the lower end of things, more laid back. Reflexes of the upper motor neuron. Reflexes are increased, except for the superficial reflexes of the abdominals, which they are actually absent. So, the uppity people are quick to reflex. Boy, they're quick to turn that head real quick. Yeah. The lower motor neurons are more relaxed. I mean, they're like, the reflexes are, they don't get too much in activity, they're just like, whatever. You know what I'm saying? The upper motor neuron, you're going to have a positive Babinski sign. And then with the lower motor, your Babinski is going to be normal or absent. They just ain't going to them uppity people, you got to watch out for them. So this is from the textbook, table 5.9. Differential diagnosis, comparison of upper motor neurons and lower motor neuron syndromes. So basically similar to what I just said on this slide, maybe a little different, so we'll kind of look at it. Location of lesion and structures involved. Well, for the upper, it's the central nervous system. Okay, that's the same. Brainstem, corticospinal tract, spinal cord. Okay. The lower motor neuron lesion. This slide adds cranial nerve nuclei and nerves. Okay. Spinal cord, anterior horn cell, spinal roots, and peripheral nerve. Let's see. See what we got here. Yep. But I have, okay, so the upper motor neuron lesion is at a level above the anterior horn cell. And this is anterior horn cell. So it looks like the anterior horn cell is the point that the upper and lower motor neurons kind of go their little separate ways. Okay. Diagnosis and pathology. The upper motor neuron lesion you're going to see in stroke, TBIs, and spinal cord injuries. Strokes, traumatic brain injuries, and spinal cord injuries. The lower motor neuron lesion, polio, Guillain-Barré, peripheral nerve injury, peripheral neuropathy, radiculopathy. So these are like the upper are kind of your major accidents, like cerebral vascular accident. Traumatic brain injury is an accident. Spinal cord injury is usually done by an accident. So your upper motor neurons are usually coming from accidents. Where your lower motor neurons is like Guillain-Barré. Nobody accidentally gets Guillain-Barré. It's, well, sort of, kind of, but it's not really done by an accident. Polio, peripheral nerve injury, I guess that could be, and then peripheral neuropathy, and then radiculopathy. Hold on, I gotta blow my nose. Okay, I'm back. Tone. Like we said, those uppity people, boy, they're just spastic. So the tone's going to be increased. Hypertonia, which is velocity dependent. So spasticity is velocity dependent. The lower motor neuron lesion is decreased or absent. Hypotonia, flaccidity, they're just kind of just hanging out there like no big deal. Reflexes. Increased hyperreflexia, clonus, exaggerated cutaneous and autonomic reflexes, a positive Bambinski. On the lower motor lesion, you're going to have decreased or absent reflexes, hyporeflexia. The cutaneous reflexes are going to be decreased or absent. Involuntary movements. With the stroke, the TBIs, and the spinal cord injury, you're going to have muscle spasms, and you're going to have flexor or extensor synergies. And it talks about that's involuntary versus voluntary. Your synergies are going to come down here for involuntary. Your involuntary movements are going to be your muscle spasms. And then with the lower motor neurons, you're going to have with the denervation, your fasciculations. Fasciculations. Yes, fasciculations. Yes. Strength. Upper motor neuron lesion. Weakness or paralysis. Yeah. This is true. Ipsilateral is going to be stroke or bilateral spinal cord injury. Corticospinal, contralateral if above where it crosses in the medulla. That's what this little word means, across. Ipsilateral if below distribution. If below. Ipsilateral if below the cross. So it's contralateral if it's above the medulla. It's ipsilateral if it's below. So same side if it's below. Contralateral if it's above. So, contralateral above, ipsilateral below. The distribution is never focal. It's never centralized. It's never like one spot. Oh my gosh, right there. For the lower motor neuron lesion, it's going to be ipsilateral weakness or paralysis. It's going to have limited distribution, segmental or focal pattern, root innervated pattern, like radiculopathy, peripheral neuropathy, segmental or focal pattern, root innervated pattern, or lowers. Muscle bulk, disuse atrophy, in your stroke patients. They learn non-use of that stroke side. So because they're not using it, that side's going to atrophy. Variable, widespread distribution, especially of anti-gravity muscles. And then on the lower motor neuron lesion side, neurogenic atrophy, rapid focal distribution, severe wasting, voluntary movements, impaired or absent, dyssynergistic patterns, obligatory mass synergies. So you're going to have your extensor synergy or your flexion synergy. And then on the lower motor lesion, it's going to be weak or absent if nerve is interrupted. I don't know what's going on with my nose right now. I just don't know what's happening. Pause. Okay. I love ebooks. They're so wonderful. You can highlight a particular word in an ebook and it will give you the definition. I love it. So a fasciculation is a brief spontaneous contraction affecting a small number of muscle fibers, often causing a flicker of movement under the skin. It can be a symptom of disease of the motor neurons. Yes. Okay, this is table 510, differential diagnosis, comparison of major types of central nervous system disorders. And it's talking about stroke, Parkinson's disease, tumor, stroke, trauma, tumor, vascular insult, complete or incomplete spinal cord injury. So, basal ganglia, Parkinson's disease, sensations not affected, tumor, stroke, sensations not affected. Some of the stuff that we just went over: muscle bulk, involuntary, voluntary, postural control, gait. Okay. And then I added some of my slides from PT school. So your upper motor neuron reflexes, Hoffman's, so HRBC. That's how I remember Hoffman's, Romberg's, Clonus, and Minsky are your upper motor neuron reflexes. There's your Hoffman's. Flick the distal phalanx of the middle finger. Myelopathy, spinal cord process, is an upper motor neuron. Radiculopathy is a lower motor neuron. For myelopathy, you're going to see spasticity, weakness, atrophy, sensory findings, bowel and bladder complaints. With radiculopathy, you're going to find paresthesia, fasciculations, weakness, and a decrease in deep tendon reflex. Patient may have a radiculopathy with myelopathy below the lesion. So, patient can have both. Clonus. That is a upper motor neuron test. Those are your reflexes. Someone who has a upper motor neuron lesion is going to have hyperreflexia, 4 plus, hyperreflexia. Someone with a lower motor neuron is going to be 1 plus, present but diminished or absent. So, if a patient has cervical myelopathy, you would also expect other central nervous system symptoms like gait changes, sensory distribution in the hands, muscle weakness, wasting of the intrinsics, bowel and bladder disturbances, multi-segmental weakness, or sensory changes. So if you're concerned about hyperreflexia, you do a reflex test and it's positive. You would probably also want to do the Clonus and the Hoffman's, and maybe even the Romberg. There's the biceps tendon. It's a test for cervical radiculopathy. Brachioradialis, C6, cervical radiculopathy. C7, cervical radiculopathy. Here again, hyperreflexia. Upper motor neuron, lower motor neuron, it would be present but diminished or even absent. Quad, Achilles, HRBC, that's how I remember it. Bembinski, Clonus. And there you go. And that is the conclusion of the stuff in the reading folder for today. Yay, yay, yay. See you next time. Thanks for studying with me. I enjoyed it.